Okay. All right. So I'm Sabah Amir. Thank you, Dr. Cohen, for this wonderful case that we'll go through now. So we have a 99-year-old man. He presented with decreased vision gradually in the left eye. His medical history, significant for COPD, some heart problems, AFib, CHF, asthma, some squamous cell he had in the past. Surgical history, he had some stents put in 2011. He had a fractured pelvis and a hip rod put in. Systemic meds included his blood pressure medications, metoprolol, losartan, aspirin, some others. His visual acuity was 20/40 in the right eye, 20/32 in the left eye, and his IOP was within normal limits in both eyes.
You still think or not? Hard to say.
Okay, color from this photo of the right eye. The media looks clear. Can you hear me?
Yeah, you can point with this, but they won't be able to see it on the internet.
Thank you. So the nerve looks pretty sharp, flat, maybe like a 0.2 cup. Some PPA, and then attention's drawn to like parafoveally here. Some areas of yellowish lesions of sugar deposits that are kind of in this like pattern. Otherwise, from this angle, maybe a spot there. Otherwise, not too remarkable. Anything that I missed there, Sabah?
No, sorry, I thought somebody was saying something.
Oh, can you guys hear me?
She asked if there was anything she missed.
You want to sit over here? Maybe?
Oh.
Why don't we make it, present it, Steve, here. This way. Whoever's discussing, maybe sits over here.
If you're discussing, you have to sit right in the middle.
Okay.
Oh, there you go.
Sabah, can you hear me now?
Yeah, I can hear you better.
Okay, you need me to repeat that or were you able to get it?
I got the most of it. You mentioned this area here, right?
Mm-hmm. Exactly.
So one thing you could mention too is you could look at that one choroidal blood vessel and see how bright it is, and it might give you an idea of what's going on in the color.
This here.
Mhm.
Yeah. There's like a prominent choroidal vessel. Maybe some like atrophy in this area. You can see it a little bit better. Some spots here. And then this is the left eye. Very similar findings. Media looks clear, nerve looks very similar. Some PPA, and then some similar stripping area here, parafoveally. And then I think those maybe are some blood spots, some heme right there in the fovea. And then some deposits, possibly drusen here and there as well. Okay, this is an IR. So you have an area of hypofluorescence in those corresponding areas of atrophy in both.
I'm not sure you use that term.
Reflectance, sorry. Hyporeflectance in these areas. So where there's atrophy, and then similar here, and then in the areas where there were some deposits as well. This is an autofluorescence. So some hypo-autofluorescence and then surrounding hyper-autofluorescence. And there's also areas that are extending superior to the nerve to an speckled pattern in both eyes, so similar appearance.
Mm-hmm.
Okay, so you see it's a good foveal contour. Media looks here, maybe this could just be artifact, but a little bit hazy media there. Subfoveally, there's a I want to say maybe drusen deposit. And then, this area here, there's like some reflectance, or forget the term on how to
It's,
describe that.
Hypertransmission.
Hypertransmission, thank you.
Or reverse shadowing. Is that settled?
I think hypertransmission.
Hypertransmission. Yeah.
Hypertransmission. Yeah, it looks a little bit disorganized here.
If it's greater than 150 microns, it's considered significant hypertransmission.
It's
Okay.
C-RORA then,
Yeah.
instead of I-RORA.
Anybody
Anybody here, it has more retinal leads, but yes, complete RPE and outer retinal atrophy, which is a fancy way of saying huge atrophy.
Okay. So that might be the area that's corresponding that we saw the color fundus photo of some atrophy. And then there's a little deposit there as well.
Yeah, so those are intraretinal.
Both sides.
I'm sorry.
Both sides. Dots, not the spots. Both sides.
Correct. Hyperreflective both sides.
Both sides, okay.
Okay, and then here the foveal contour is a little distorted. Some parafoveal intraretinal fluid cysts. And then also some disorganization here subfoveally.
You gotta stay where you're pointing, they can't see. you
Oh,
point.
sorry, yeah, like right,
In the center,
subfoveally in
yeah.
the center.
That's great.
Yeah, I don't really see this. Oh, maybe here, this is the area of some atrophy a little bit. Trying to find where the area of atrophy is. And then very similar findings here, parafoveal, intraretinal fluid, disorganized, outer retinal layer.
Like disorganized, if you're describing that on the boards, we want to call that subretinal hyperreflective material, because it's not really that
Or
disorganized.
stuff on the bottom.
Yeah, that's not
But
really.
here?
You're talking about that.
Yeah, because you say disorganized, people think you're going down the drill road, which is not present.
Okay,
You call it SHREM, which is almost famous ones, is subretinal hyperreflective material.
so some subretinal hyperreflective material in these areas, and then some intraretinal fluid cysts. I think this was this is what Zoom did from one of the prior OCTs, highlighting similar findings.
What she pointed to briefly was
This thing?
that little thing there.
Okay, then it's intraretinal hyperreflective spot.
Yeah, and it almost looks like a vessel. Almost looks like a dilated vessel. It's hard to be sure.
Okay,
You're better, you're more, it's better to say just hyperreflective, it's a funny shape.
yeah, kind of like an oolong shape.
Mhm.
Okay, so this is an FA. Looks like we're at a later stage. All the vessels and arteries are filled.
Okay.
So it looks like maybe currently there's some staining or pooling. I don't see like any expansion of the areas here.
So if you're describing an area of atrophy,
Mhm.
there's five causes of hyperfluorescence. I just remember there's five, and I don't remember what they are. There's window defect, staining, pooling, leaking, and autofluorescence, right?
Mhm.
So that
So for this specific thing, most probably I should have.
window defect. So now it is true that the fluorescein staining the sclera and you're seeing it. So it is staining the sclera, but if you're going by the book, it would be window defect.
Yeah, that makes sense.
So what phase were those?
Okay.
We go back a little bit. What's that?
Was there one before Sabah, or was it just black? Okay. I want to say arterial.
Good. Arterial, and then keep going. Still the arterial, and then this one's full.
AV.
Yeah. I like ICMAP. You used to use P
Transit, I like to say transit.
At some point you said
I
P.
said transit, but I.
Both purple.
Oh.
Infusion center. Gold, purple, infusion center.
Okay, so, some areas of. I think that's similar, it's probably a window defect, I think there was some
You can
atrophy
wait a
there.
couple, you can say hyperfluorescence, and then once you get a couple more images, you'll know more whether it's leaking or not.
Then some areas here.
Okay, keep going, good.
Those look like that's kind of expanding a bit.
Good.
Some leakage,
Perfect.
blurry, and then here's a window defect.
It's a nice difference between staining and leakage there. It's a good example, because they're right next to each other basically. Look at the borders on the leaky one. It looks like a picture that's out of focus. Look at the borders on the staining one. It looks like a picture that's in focus. That's pretty.
Neat shot.
What was the patient's complaint? Vision loss in the left eye, right eye. Really?
Yeah. Is there a zinger here, or is this not the case? Not going to have a zinger?
I don't think it's gonna.
I don't think it's gonna.
I hope there's no zinger.
It's something, you gotta mix them up. So some of the cases are just kind of things you need to know, and I have some really wacky cases. I can't decide what to do with them because they're just so crazy.
So
but-
this is more helpful.
Yeah, this is more, this is something you
I
actually,
think wacky cases for like the end. of-
yeah, the end of the year, and maybe one I try to be one or two per conference, and like really nutty ones.
Okay, so this is an ICG
Yeah, the right eye.
of the right eye, kind of like you pointed out, the prominent choroidal vasculature that you can see.
Right, which you're supposed to see on the ICG, but you can see how it's different, you know. And mostly the ICG is to look for plaques for neovascularization. So you're looking for a plaque, which isn't really there. Honestly, if the OCT showed something superior to the macula, you would probably call that a plaque. So this ICG is just kind of nondescript, normal.
The normal ICG. And then ICG of the left eye. Not sure if these little spots mean anything.
Yeah, maybe.
Oh, okay.
So those are hyperfluorescent spots, I guess you could say.
Okay, it was that correlating to the area of leakage, or is that a little
Yeah.
bit more inferior?
Same spot. No, it's right
Same
next to
spot.
the.
Okay, so maybe some choroidal neovascularization in those areas. Okay, so we had 99-year-old male with some progressive decreased vision in the left eye. Findings were fluid, intraretinal fluid. We had areas of atrophy, some areas of leakage and choroidal neovascularization. And then medical history seemed like he was a vasculopath, and then history of radiation to the head. Pertinent.
I just kind of summed up everything that we went through here. And those that one hotspot on the ICG we saw, hyperfluorescent lesions on the FA, which corresponded to the leakage areas. And then the OCT with the hyperreflective lesions as well, and the subretinal one. Any differential?
So you have to consider all the things that would cause choroidal neovascularization. So maybe AMD, also the areas of atrophy. Could be I'm kind of drawing a blank right now.
You can always see myopic degeneration with the MD. It's like hypertension and diabetes. There's automatic second differential.
And then one of the tricky things in this case is if it's macular degeneration, there actually are some subtypes. That's where this case is going.
Yeah.
Unfortunately. So you've got, so let's say I threw some stuff. So is this, there's type 1, type 2, type 3 neovascular membranes, but also we talk about polypoidal vasculopathy, we talk about classic occult, we talk about retinal angiomas proliferation. So you could say it could be one of those things. If I was looking at it, I would think on the ICG looks a lot like polypoidal because there's a it looks like a polyp. excuse me, but there's not a branching vascular network. So then I'm thinking, well, maybe it's not polyploid, and the OCT doesn't look like polyploid. So then you get the other differentials.
So if you look at the OCT, where is most of the fluid that you saw?
It seemed like parafoveally,
It was it
Or sorry.
subretinal or intraretinal?
intraretinal.
That gives you kind of a clue
Yeah.
of where.
Which membrane type it is? Okay.
Or where the CNV is.
Yeah, that's very nice differential, Sabah.
Okay, so this is a retinal angiomatous proliferation, also known as type 3 neovascularization. Can you guys hear me okay?
Yeah, you
Yeah.
sound good.
Okay. Sorry, I think you guys are a little bit muffled, but that's okay. It is a subtype of wet AMD. I think Dr. Cohen just mentioned that. There's type 1, which is the occult neovascularization, in which the CNV is sub-RPE. There's type 2, in which classic NV, the neovascularization expands to the subretinal space. And then there's this type 3 retinal angiomatous proliferation. This was a very good case for me too. I've seen this a few times in clinic, but never with so much imaging. So I really appreciated that. In this condition, new vessels come off from the retina. It's characterized by retinal or retinal choroidal anastomoses, and these patients are usually older than the typical wet AMD patients. So in the studies, they say 79 versus 76, so a little bit more older. High risk of onset of RAP lesions in the fellow eye. So 80% have the fellow eye affected after 1 year, and almost 100% before 3 years. So it is primarily a bilateral condition. There are different classifications for these lesions. There's stage 1, which is the intraretinal neovascularization. The proliferation originates from the deep capillary plexus in the perimacular area, and it's confined within the retina. So it only consists of the retina to retina anastomosis. Intraretinal hemorrhages and edema is common, and there could be telangiectatic vessels. And actually, there were some telangiectatic vessels in this patient as well. I can actually go back and point those out. Can you guys actually see my cursor on the screen as
Yes,
well?
yeah, we can see yours, yeah.
Oh, okay, very good. So here I thought there was a good, I think this was the photo that it looked like there were some good telangiectatic vessels. Did you think that, Dr. Cohen?
Yeah, I think so. And then the fluorescein of that eye shows the vessels being that one image. Right. You keep going forward. Right. Keep going. A little farther. There.
Yeah,
Yeah, that looks like the vessels are a little bit wiggly. Yeah, I think so.
right. Okay, so back to this. In stage 2, it's subretinal neovascularization, where the neovascularization invades the subretinal space. Serous PEDs can be present, and there's increasing edema and hemorrhages. In stage 3, choroidal neovascularization, there's CNV, which is sub-RPE. It can also be associated with a vascularized PED, and a retinal choroidal anastomosis is formed.
And
So
my type 1, 2, 3 is type 1 is sub-RPE, type 2 is subretinal, type 3 is intraretinal source for the CNV. So it kind of goes in order from the bottom up. So that's how you can remember type 1, 2, 3 CNV. It's kind of more or less like, does that make sense?
And then as progression of the type 3, it goes back the other way.
Yeah.
The 3 goes down into the choroid, but the 3 has these, like that OCT that was zoomed in on with that thing that Dr. Cohen foreshadowingly said looks like a vessel is a perfect example of like an immature but active type 3 replication. It was like a classic pattern. Everything in ophthalmology is pattern recognition.
So RAP lesions differ from typical wet AMD in that these patients are older. There's more intraretinal changes, so hemorrhages, exudate, and fluid are more common. It's very rare for them to have large subretinal bleeds, but they can also have pre-retinal heme. It typically does not occur at the fovea. The initial lesion is extrafoveal since there's a foveal avascular zone, and it can be harder to treat with anti-VEGF. On imaging, so OCT, you see more intraretinal cystic spaces, hemorrhages, exudates. They can have PEDs, which this patient didn't have. On the FA, it can be difficult to differentiate between the classic ocular occult, sorry, I meant to write occult there, and early RAP lesions. And then ICGA can show hot spots. I also saw this hairpin loop in my research where there's a linked retinal arteriole and a retinal venial, but I don't believe this patient had that. And it was kind of hard to find a good picture of it too. In terms of treatment, they respond well to anti-VEGF. There were these studies done back in around 2010, spanning several years, called the Comparison of Age-Related Macular Degeneration Treatment Trials. And they were treated with intravitreal ranibizumab or bevacizumab in the eyes with RAP, and they were found to have less fluid, FA leakage, scar, and subretinal hyperreflective material when compared with all other eyes with wet AMD, but without RAP. Visual outcomes were better at 1 year, but then these differences didn't persist at year 2. And the eyes with RAP lesions were found to have more geographic atrophy than eyes without RAP. There were some other treatments proposed as well that I found in my research. Laser for photocoagulation of the fetal vessels, which is the hotspot areas, and plus or minus, I saw intravitreal triamcinolone to reduce exudation. And then there was this unclear role of PDT, since that more targets the choroidal vessels, and this is originates more from the retinal vessels. I did want to ask you about that, Dr. Cohen, or Dr. Any of the other retina docs here, if you could comment on that.
I'm probably the most PDT person, so I'm the oldest. The PDT, I probably wouldn't be a good idea for this. We PDT rarely, although I have to say I've seen about 5 or 6 people the last 3 weeks or so that have done really well with PDT with me. So the PDT wouldn't be a RAP thing nowadays. Subretinal surgery was kind of interesting with the something interesting because when you did the subretinal surgery, if they came off the retina, you'd end up like pulling the outer retina at the time of removing the neovascular membrane.
Right.
So.
Yeah, I think most of us, I can't remember the last time I PDT'd a wet AMD patient, but I think it would be a good tool to have in your toolbox for like a non-responder or a Q4 week. I don't know what.
Oh yeah, that's why all these patients with wet AMD, I love the PDT. Like if it's non-foveal for non-central lesion, it doesn't respond.
Patients who are not responding or you can't extend them, and it's kind of a leak on the out, like not in the fovea, then yeah, but that's not really common because they respond so well to anti-VEGF. I use it a lot for central serous. So my main thing.
Yeah.
When was RAP really defined? Because I feel like when I first started,
you
would see these horrible, like, and you see the retinal choroidal anastomosis and those like end stage RAP.
Right.
And that's how you saw RAP at that time, and they were really horrible. Now you catch it so early and they seem like so minor, the lesions, so minor.
I think probably with the SLOs, when we started getting Heidelberg,
yeah.
when we started getting the fancy imagers,
I just remember first starting, you saw all the end stage RAPs.
The other thing with RAP is they in the early days of anti-VEGFs, they were going to exclude these.
Yeah,
they did
they still exclude them from the Opthea study.
Do they? Yeah, people don't like RAP. The RAPs they tend to do. Oh, now I think they do okay, but people are nervous about them.
So the only other thing I'll make a comment on, if you go back to the fundus autofluorescence.
And can you hear us, or are we really muffled? I'm going to try to play with the mic.
It's better now than it was before.
Okay.
I hear you great.
Okay, good. Because I might be able to go back.
If you look at the superior macula in each eye, what are you kind of seeing there? That kind of gives you a clue to the risk factors of this patient.
The IR should show it too.
It doesn't show very well.
No, let me go to the IR. Where's the IR? Go back one. Yeah, they're kind of there.
Not as.
Okay, yeah, the FAF is nice. So it's a type of drusen.
Particular.
Particular drusen.
But so let me ask another question. This is a great slide for, so 100% of the retina specialists and residents here are treating the left eye, right? Vision loss, wet AMD, we're treating this. You're getting shots starting today or next week. Is that correct?
Yeah.
How many of us are talking to the patient about cyclovia or Izervay for the right eye with good vision, non-central geographic atrophy? Are any of us talking to this patient? Because at
Not
99, at 99, if you give it monthly for a year to 3 years, they will maybe have some visual benefit. Any of us talking to this patient?
I didn't realize this patient's 90 minutes. There's no way. I think that the evidence for any of these anti-complements are not, I mean, let's face it, they're okay. I tell some of my patients, I'm like, they're okay. They're not great
He has
yet.
more of a chance of developing wet AMD and
Yeah.
fellow eye, and, you know,
I feel like this patient has more it's like, don't mess with what's not gonna blind them imminently.
And this is the flaw in the pro forma for the dry AMD drugs. 100% of us, no question, treating the left eye in this 99-year-old. 100% of us, no question, not treating the right eye with the same basic indication for treatment, which is the disconnect between the volume that was projected and the volume that's getting.
Oh, do they project the volume?
Oh, yeah, of course, yeah. I raised the money.
I've done that, yeah.
You've done that too. You know, I've done that. We've all of us who are entrepreneurial kind of sell a pro forma, and that's the flaw, because I get all these conversations with the investors. Why are the GA drugs not performing? And I talk about basically this case.
Right.
Why are they not making their numbers?
Well, when I tell the patient about the GA drugs, I always say it doesn't improve it, and it doesn't stop it. It slows it. It doesn't slow it by 50%. It slows it by about 20%.
Yeah.
And so it's just
so
not.
a 99-year-old, that's a
Right.
good sell.
Do you guys have any of the anti-complements on formulary yet that you have?
Now, let me ask that question one other way. Let's say this patient came in looking just like this without the wet AMD in the left eye, complaining of vision loss in the right eye. Are you talking to this patient with pure geographic atrophy about complement modulation at that point, or are you talking
The left eye, I would talk, if the left eye was the good eye and
they're coming in
75, I might treat the left.
They're coming in
Yeah.
symptomatic of the right eye.
Right.
though.
I
So
would treat the right eye if they were 75.
Yeah,
No, I
if
would
there's
I would treat both
75,
eyes
that's
if they're
a
75.
Yeah.
Well, yeah.
I'd start
I'd start with the right
yeah.
eye and then.
Yeah.
Yeah, okay.
Because the right eye is still
Left eye.
20.
I would
I would
push the
end up
left eye,
treating
because you're not gonna
bilateral,
stop
but
it. The patients, you're offering a treatment for eyes losing vision, it's not gonna help them. Right?
Yeah, not gonna.
It's not gonna stop it, it's not gonna slow it by 50%, it's gonna slow it by 20, so they're still gonna lose vision, then they're gonna say, you're treating my right eye, I lost vision anyway, why should I treat the left eye?
I would start treating.
That's what
I
I
would
would
probably start with the right eye, just because for me, I'm still new with these
Yeah.
drugs, just to try it out, but probably would shortly thereafter start in the left eye.
I would
They would get
I
bilateral.
would go right to the left.
I would start with the right eye in case they develop horrible vasculitis.
Right.
Oh.
Just because
Yeah,
I
that's
want to
just
see any
they just need, I just need a test balloon in the worst eye. I used to start both eyes same day, but now I would
I
talk
do
to
the-
them, send them home, bring them back, start with the right eye, and then go promptly to bilateral. It's really interesting, and we're not aligned on this, but we're all aligned to treat this 99-year-old with monthly injections in the left eye until they die in 10 minutes,
Because
for
you
wet
get a
AMD.
quick- get a quick-
Yeah, videos.
And it improves.
Then it
It's a
It
treatment.
gets better.
Yeah,
It's a really
treatment
pretty
that
good
works.
drug. Yeah.
All right, it's good, Sabah, you're doing great. Still there, right?
Yes. Thank you. That was an excellent discussion. I think I just have one more slide.
Well, they do. Isn't that cool? Oh, yeah, they shrink up. Yeah, we can get line cuts through it, but the map does that, shrinks up.
Yeah.
Yeah, it's so gratifying. It's so ungratifying when you treat with the GA drugs.
Right. These are really nice.
Is he still lost to follow-up, Dr. Cohen?
Yes, yeah, it happens.
Yeah.
Well, we know what happened.
Yeah,
Yeah.
probably. He probably moved to Bermuda, just living the good life. Have you ever read there's a good book, The 100-Year-Old Man Who Stepped Down? There's a good book on the 100-Year-Old Man who did something. It's a really cute book about a 100-year-old guy. Good time for a light read.